All right, so let's get into part 2 of chapter 11. So, what do we carry? Well, in our trucks, we carry oxygen, oral glucose, activated charcoal, aspirin, and while this does say epinephrine, here in our area, epinephrine's actually in the drug box. So that's not one that we're going to carry that you can administer without talking to the patient. Oxygen, oral glucose, activated charcoal, those are all drugs, and aspirin, we do have those in the truck and don't require a prescription. So how do we administer it? Well, there's peer assisted, so your partner on the truck, your attendant in charge, a firefighter, they may help you give a drug. There's patient assisted, which means that you are going to give them the drug and give them directions. And then there's EMT assisted, and there's a few times where basically without you delivering it, your patient will die. And so we'll talk about those as we go through the chapters. How you give and when you give the drug is going to be determined by the protocols and by medical control. So your protocols can say one thing, but if you call medical control, they may override that, or they may make it stricter and say no, even if protocols would normally allow you to. We decide as a state, and then even within the regions, which drugs are carried on your ambulance. As an ALS provider, those drugs are going to be impacted by the availability. So when we have drug shortages, our drug boxes will change. Otherwise, for the most part, everything is good. So oral medication is one of the most common ways to take a drug. It is ease of access. We've all got mouths, and as long as we're able to, we can swallow. And a lot of people are comfortable with it. And this is whether it's in pill or liquid form. Disadvantages are that the administration of an oral medication can actually take longer to reach the body and become effective, because that will impact the ability to absorb. If you're stressed, if it's a full stomach, an empty stomach, they're sick, all can impact an oral medication. We have to make sure that our patient can take an oral medication. So I need my patient to be conscious and oriented. I need to have them to have a well-maintained airway so that there's not a risk of them accidentally inhaling the medication instead of swallowing it. One of the oral medications that we give is activated charcoal. So activated charcoal is given in overdoses when you've taken a medication or ingested something that you don't want absorbed. It is a fine powder, so what you see there in the pill, that's not how it's normally carried on the ambulance. Because it is an oral medication, we need our patient to be conscious to give it to them. Oral glucose is the next medication that we give orally. I know, oral glucose, orally, duh. So this is not prescribed. We carry this on our truck. And we give oral glucose for hypoglycemia. So hypo means low, glycemia, sugar of the blood, so low blood sugar. Again, because it's oral, we do not give it for a patient who is unconscious or with an unprotected airway. So even a semi-conscious patient, we're probably going to reconsider giving this to. And finally, aspirin. Aspirin, again, non-prescribed. It's in the drug box, in an unlocked portion of the drug box normally. We don't give aspirin in the field for reduction of fever or pain. Honestly, we don't even give it for the inflammation. We actually give it for the cardiac emergencies. So we're going to use it during a heart attack because of what it does to clots and to the bloodstream. Why we don't give it, and we'll talk about how we find these things out in our patients. But if they're allergic to aspirin, if they have asthma or bleeding disorder, we're not going to give aspirin. So, these are all things we're going to think about. And because it's oral, they've got to be able to swallow or chew it. So we give sublingual medication as well. Sublingual, meaning under the tongue. And one of the things that's great about these is it's easy to explain. Hey, put this under your tongue and let it absorb. It's going into the mucous membrane that's there in the mouth, so there's a quick absorption right into the bloodstream. The problem here is if you've got a patient who doesn't follow instructions, you've got a patient who loses consciousness, it may cause an issue during administration. So you've got to constantly evaluate the airway and make sure they're following instructions. The drug we give sublingually is nitro. For the most part on our trucks, we carry nitroglycerin in a compressed pill. That's the bottom picture you see on the screen. What you'll see in the field, though, is a lot of patients will have a prescribed spray bottle, and you either put the pill or you spray under the tongue. The action of nitroglycerin, what it does is increases blood flow by dilating the veins. So it relaxes the veins, opens them up. So where there was a clot, it's now going to be bigger and blood flow is going to be easier. Nitroglycerin can drop the blood pressure because, of course, it's expanding the blood vessels. And this is the one drug where you need to ask if they might be taking erectile dysfunction drugs, because actually erectile dysfunction drugs were created originally for chest pain to treat angina, but there were some side effects, and so it does the same thing, and it's like giving a double dose. One of the side effects, though, is also that it may cause a mild headache, but that's actually a good thing. Sometimes side effects are positive to show that the drug is working. We normally give it in a tablet. In the truck, it is there, but we normally give only those prescribed to the patient. So I'm not going to give off the truck as an EMTB. I'm going to give the patient his own medication. It's one tablet at a time is your dose. If we have that metered dose spray, it's going to be sprayed on or under the tongue, and one spray is equal to the same dose as one tablet. So some of the considerations when we give the sublingual for nitro, whether it's the spray or the tablet, is the monitoring of the vital signs. As you'll see on your protocol sheets for the grading of your practical skill stations, there is a reassessment. And after we give a drug, we need to reassess. Is it working? We've now given an intervention. So we are going to wait and see, how do the vital signs look? How is my patient's pain now on a scale of 1 to 10? Because each drug may have a maximum dose. And so for nitro, your maximum dose is going to be 3 pills total. But I can't give 3 in a row in case it causes some negative side effects. We're going to give intramuscular medications. There is one drug that we actually do get to inject, and that's epinephrine. It goes IM, intermuscular, which means it's going to go straight through the skin into the muscle and then get absorbed. So I don't need to find a vein, which even as an ALS provider, I'm not great at, so that makes me feel better. There is constant and steady blood flow to the muscles, so it's going to flow. Once it gets into the bloodstream, it's going to move quickly. Problem is, it's a needle. So if your patient's not a fan of needles, there might be some problem here, because especially your EpiPen, that's a pretty massive needle. There's going to be pain associated with it, and patient might not be too happy. Plus, you have to consider removal of the sharp object once you've used it, an appropriate disposal. So the drug that we give intramuscular is epinephrine. Also, you probably know it is adrenaline. This controls our fight or flight response. We give epinephrine an allergic reaction. We expect when we give an epi to see an increase in heart rate and a constriction of the blood vessels. So it's going to take that heart rate higher, it's going to make those blood vessels smaller. Think about it. When you've got a dose of adrenaline, when that bear jumps out of the woods at you, you're probably going to jump and you're going to feel very anxious. And that's exactly what epi is going to do. Because it constricts the blood vessels, we've got to be cautious about the impact on the blood pressure. This is that drug that we may deliver without the patient's help. Because if I don't give epi when they're in an allergic reaction and unconscious, my patient will die. picture of intramuscular administration. The problem with this picture that I have is really you want to expose the area of skin where you're giving the injection so that it can get directly into the skin. It's going to act as an antidote and reverse histamine response. This is a dosed epinephrine pen, which means that one pen equals one dose. There's a pediatric dose and an adult dose, but one pen from your patient, because it's got to be prescribed, is going to be your dose for this. Now, the big one that's coming out now is naloxone. Naloxone, of course, is used to reverse the effects of the opioid overdose. The goal to get naloxone into the hands of many drug users means you may arrive on scene at a public place and someone's already administered naloxone. Or law enforcement may have been first on scene and they've already administered naloxone. And in reality, if it's not an opioid, naloxone's not going to do anything. It's actually not going to have any positive effect on the patient. Most common for us is naloxone in the nose, so intranasal medication. We're going to spray it in a fine mist into the nasal passages for absorption. And as it said on the previous slide, you've got to be careful. Naloxone will cause them to lose their high very quickly, and they can actually become conscious very violently. They'll come up swinging. Okay. We give some inhalation medications. We talked about it in chapter 10. Inhalation medication, the first one, the most common one, is oxygen. We're going to deliver it via non-rebreather, and that's going to be 10 to 15 liters per minute, or nasal cannula, which is going to be normally 2 to 6 liters per minute. We're going to give MDI, and I remember the first time I saw somebody say this, I thought, what are you talking about? MDI stands for metered dose inhaler. So your metered dose inhaler or a nebulizer. If you've got kids and they've ever had RSV or other problems, you might have been sent home with a nebulizer. The problem with that is that I, as an EMTB, cannot give a neb treatment in the field, even if I've been trained to give it to my own child. The reason for that is it's not a measured medication. So the metered dose inhaler, the standard inhaler we all think about, that every time I squeeze down is going to give the same dose. So we are able to give this. Excuse me. Why nebulizers and inhalers are better is it aerosolizes the medication and puts it directly into the lungs when taken appropriately. Your patient may have a spacer, and what that does, you can see it in the picture there, and that helps breathe in. So the whole aspect of using an inhaler, especially in children, can be a hard concept. So the spacer helps make the mist even more so to take it in and not lose as much inhaler, as much medication when they do take the drug. Small volume nebulizer is another option, but again, as an EMTB, you're probably helping your ALS provider administer this. You're not going to do it yourself. Again, it's an inhaled medication. By doing a small dose, it takes longer to administer, so it may actually help your patient if they're anxious, and it can also be used on a CPAP or during BVM ventilation of your patient. We do see things such as rescue inhalers. Rescue inhalers are placed, these used to be over-the-counter inhalers. So they're bronchodilators. They're going to make the bronchioles wide, make them get bigger. Really, these are used for short and fast onset difficulty breathing issues. So one of the things that you have to do, if you remember in the patient assessment, is ask sample. Remember sample, signs, symptoms, allergies, medications, past pertinent medical history, last oral intake, and events. asking about medications and following that up with past pertinent medical history will give you clues as to what could be going on. But just because they don't have a history doesn't mean that they aren't having the problem. The problem that rises, though, is if your patient's having difficulty breathing, but they've never been diagnosed with asthma, then getting the actual medication won't happen because they've never gotten a prescription if they've never been diagnosed. So you have to get a good interview of your patient in order to make sure that you find out the most important stuff to treat them. Another issue that will arise, that I hope never arises, is medication error. So using the wrong medication, or using the right medication at the wrong time, or not using a medication when you could, or using too much. One of the things I tell people all the time is take your time, read the medication, ask the right questions, and administer at the right time. That reassessment is also going to be very important, especially if there's another dose to give. If the medication error does occur, you've got to document it. You've got to talk to people, and you've got to notify medical control of the error. Did you give too much nitro and now their blood pressure is going too low? Did you not give the EpiPen when you should have? You've got to document why, what did you find, and why did you decide to give or not to give?